Oklahoma Medical Centers, Oklahoma Community Medical Centers. Yes, and she has spent a lifetime of work serving the underserved here in Oklahoma, but also in India. She spoke last year at the conference and had just a wealth of wonderful information to share with us. So we were very excited to invite her back, and I hope you all enjoy.
Thank you, Tim, for introducing me. I'm so sorry that I was having some technical difficulties. I think it's my server that was trying to work from my office computer, and I probably should have thought about it, but I didn't. And thank you for pulling that PowerPoint for me up again. That's wonderful. So I just made some changes to my PowerPoint from last year. Who do we have in the audience? Since I can't see anyone, it's kind of hard to know who I'm talking to. But do we have students, medical students? Who do we have in there?
We have a lot of medical students. We have some faculty, some family and friends of students, but I would say mostly medical students.
Okay, great, awesome. Thank you.
If there's anyone else I left out, chime in.
Oh, sure. Yeah, no worries. I just want to just kind of give you a history of, how I got started with serving for the uninsured in Oklahoma, and a little bit just a brief about me and what inspires me every day to go do my work, and see if that inspires you to do the type of work that we do at community health centers. So as Tim introduced me, I'm the Chief Medical Officer for Community Health Centers, and which is a federally qualified health centers. And we are about 6 health centers. I have served primarily at the Healing Hands Healthcare for the Homeless. And I just, Tim, can you go to the next slide? And I just want to say who I am, where I came from, and what I'm doing. So this is where I came from. This is my city that I love. And this is where I grew up, where I went to medical school. And I wanted to share a little medical school story with you guys. I grew up in a large metropolis with about 18 million people, and a chance of getting into medical school there was about just the same as a chance of being a NBA basketball player. But I was determined to go to medical school. I always wanted to be a doctor since I was 5 years old. And I think I just got lucky in addition to the determination factor, because the chance was so small. And then after 4.5 years of grueling hard work, I wanted to share this picture, this image, because this is very dear to me. This is where I celebrated my medical school graduation with an ice cream from a street vendor right there where you see a lot of people. The first slide, right, where the seawall was. Yeah, this is the seawall of Bombay, or now known as Mumbai. And at that time, we may have had clubs and bars, but I just wasn't aware if there were any. I was so sincere in my work that I didn't have time to celebrate in any other way but an ice cream. So the next slide here, and I want to show my next slide here. This is also very dear to me because these are the guys who would deliver, that was the highlight of my day. They would deliver my lunchbox. This is a big lunchbox with 4-tiered different types of food that my mom would prepare, and it would be delivered at noon sharp at my school. And I ended up not eating it and sharing it with my friend who didn't have any access to fish because she was a vegetarian, and I would eat that. I would eat hers and she would eat mine. But these people are so good at what they do, is that they actually deliver with a very, very small error. It's about 3.4% error of not receiving your lunchbox, way better than Uber Eats and Postmates. These are the forefathers of those guys. So anyway, this is where I was in Mumbai, and I want to get to the next slide, which shows you how I came to Oklahoma City. And so I came here and I did master's, and I came here to pursue a master's in public health from a nudge from my mother, who wanted me to explore the land of opportunities And I wasn't really that interested, but I said, oh, well, let me just check it out anyways. So I came to Oklahoma City, of all the places in the world, and I settled here, and I love the city. And this city is very dear to me now. And I always had a heart to serve, the ones that didn't get access. Even when I was in India, I wanted to learn something about leprosy, and I was actually working with patients with leprosy before I came here. So I wasn't very happy about coming, but I came anyways. And then I found that I can find something else that I can explore. And so I found where I could work with the homeless. And part of that is because I wanted to balance my life with my children, and started working with the homeless here in Oklahoma City. What I want you to understand is homelessness is, these are not bumps on the streets. This is something very difficult, very real. And I wanted to share with you who these people are, and why they're there, and what we can do to improve their health. So on my next slide, I'm gonna show you what Oklahoma is. 100 people. I call this slide. This is from 2016, and I think it's just gotten worse, not better. But this is where we are in Oklahoma as 100 people. And I think if you look at the percentages of who are these Oklahoma's 100 people, it's a very busy slide, but it'll show you that about 17% of our people in Oklahoma live below poverty line, and they experience food insecurities. About 21% lack health insurance. 29% live in areas that are primary care shortage areas. There is no access to primary care. 16% of our people have disabilities. 33% people are mentally ill. And 68% people are either overweight or obese. And 21% smoke. So imagine with such unhealthy population, a small minor injury or an illness can throw you into homelessness. So it's very easy to become homeless when you have a population like that. Want to get to the next slide. I want to show you what homelessness looks like here in the city. So this is a slide that I went out, and I like taking pictures. I used to, at least when I had a little more time on my hand. So I took this picture, and this is where one of my patients actually lived inside here. And I went to find out if I wanted to give him what we call an injection I was trying to get some medication from medication assistance program, because he had clots in his legs, and he had no access. So I had ordered some medication, and I wanted to deliver it. So I went here and I took a picture of this place that he was staying in. Could you do the next slide, please? And so I want to say, I like this slide. This other slide that I like, that when I took pictures, is I like this slide because it shows you besides what I have in white on the background, you will see two signs. It says, one says liberty and justice for all, and the other one says no trespassing at any time. That I think is really deep. So we do things that are exactly opposite of each other. Are we really achieving anything sometimes? So you have to think about what it is that we can do to bring things together. Here on a single day in Oklahoma City, there are about 1,300 to 1,500 homeless individuals, and 60% are males, 39% are females. Few are transgender. Some people actually have families. They're homeless families, not just males and females, but there are children. And there are 15% youth below the age of 24. Tim, can you go to the next slide? And then this is one of my other patients who was pulling out beer cans to sell and make some money. But he is, 58% people live in the shelters, 12% live in transitional housing, and 30% are on the streets right now. So go to the next slide. And 22% of the women who are homeless are a result of domestic violence. And 33,445 children were enrolled as homeless in our public school systems. This is not a guy, and I wanted to show you this because 40% of the homeless, this guy was a veteran, 40% of the homeless in men have served in the armed forces as compared to 34% of the general population. So they're not just bums on the streets, they're people like you and me that have had bad health and probably not enough social support, no family support, and they're on the streets. Can I look at the next one? And then of course you have your mental illness. You have about 30% of people are severely mentally ill, not just a minor depression and bipolar disorder, but people have diseases like psychosis and schizophrenia that make it impossible for them to work. 30% do have addiction disorders. And can you go back to the previous slide? I think there was something else on that I wanted to point out. And then 18% have physical illness or disabilities, other disabilities like neck injury, back injury, and other issues that, or severe diabetes, uncontrolled high blood pressure, and other chronic illnesses. So can you get to the next slide? So at Healthcare for the Homeless, which is right here in downtown Oklahoma City, it's a satellite of Community Health Centers, is one of our clinics, of the 6 clinics. We serve the homeless, okay? And we also outreach the home. We also serve the homeless at Salvation Army, at City Rescue Mission, at some of the rehab centers like Jordan's Crossings, YWCA, and several other places. Can we go back? There we go. And so what we try to do is we try to provide them comprehensive, accessible care at no charge, absolutely zero charge. We address their chronic illness, their acute illnesses like pneumonia, cellulitis, or whatever it may be. We try to provide them with medications that are completely free to them. We provide lab, x-rays, mammography. We have limited dental care for the homeless individuals. We also try to make referrals to specialists through Health Alliance for the Uninsured, which is another agency that helps to get people tied up with specialty care when they don't have any access to specialty care. And we provide them transportation. We pick them up, we drop them, we take them to eat their meals back on time. And then we go back and drop them off. And then the only thing we don't do is they tuck them in their bed in the shelters. But we do a lot to try to, make them feel human again, and wanted again and cared again. We also provide behavioral and substance abuse services, which is a very integral part of treating a patient. So we can go to the next slide, please. Thank you. So not only do we provide them care while they're homeless, but we also provide them health care for about a year after they've been in housing. And after that point, we transition their care to low-cost care at community health centers. We have health centers in Oklahoma City, in Spencer, Kearney, Langston, and Shawnee, where usually after when we transition them, they have to pay like a small copay, like a $30 copay for their visits, which is a very inclusive visit. It has labs and x-rays and several other things. So it's a very economical way of getting the healthcare. So I think that's a federally qualified health center. We are a federally qualified health center. We receive grants from the federal government every year. And we provide, with that money, we provide comprehensive primary care with linkage to specialty care. For all those who are geographically isolated, we go into rural communities. We have a clinic in Kearney, Oklahoma. We have a clinic in Langston, Oklahoma. We have a clinic in Shawnee. And those are the places where, and of course, in the city, we have a clinic in the zip code 73111, which has 4 times the morbidity and mortality of the rest of Oklahoma. So we're always trying to reach places and people that don't have access to care. So this is just a list of our health centers. If you go on to the next slide. And I wanted to say that not only do we provide access to healthcare, but we also believe in providing quality access, quality to these patients. And 4 of our 6 sites are being accredited as uh, PCMH, or they call it NCQA accredited PCMH, patient-centered medical homes. And what that means is we provide, we provide comprehensive, accessible, affordable healthcare that's coordinated, that we follow up our patients, that we provide them case management, we provide them case coordination, we look into it in the registries, we make proactive calls to try to get them back to the clinic when they're slacking off. So that's why we get this certification. It's not easy to achieve that, but we try to maintain that also, to give both quality and access to patients. So the next slide, and with that, I want to say that we are at the forefront, um, and we have been at the forefront from before governors did announced emergency on March 13th, it was, I think, and we were a couple hours before that, we had already announced an emergency and already started with our COVID response. So we are at the forefront of the COVID response. This was one of our pictures at our Shawnee clinic when there was nobody doing the testing. We had started drive-through testing in Shawnee, Oklahoma. The next slide I want to show you is just that our COVID response, we're continuing to do drive-through testing at several of our sites. We also actually established a drive-through pharmacy as a result of the COVID pandemic, so people can drive through. We are doing weekly screenings at shelters, which is one of its kind in the nation. So we coordinated with START Coalition, which was several people from Duke and Harvard who, for some reason, chose Oklahoma City with OMRF and asked us if we could do screenings at the shelters and keep our homeless safe. So we started doing that probably in June or so. And so far we've done 7,000 COVID tests at shelters, clinics, and through our drive-through clinics. We are also part of the state distribution plan for the COVID vaccine, and we've given 3,000 COVID vaccines at our different sites. Should we go to the next slide? And so I want to say that what makes us different from a regular clinic or private clinic is that we not only focus on the individual care, that's as pretty evident from the fact that we are patient-centered medical home. Patient is in the center of our care, but we also do a lot for population health. We look at our people as a whole, as a community, and we look at their needs and we assess which areas are they lacking? How can we, collaborate with other agencies to make their lives better? So population health, we have an EMR certified technology, which is very helpful in doing population health. So we have registries for diabetes, hypertension, so we can follow up and actually make changes and impact in their lives. And population health is what determines your health policies. Go to the next slide. So all the data that we collect from population has impact way beyond your individual health. This has impact on health policies. This is how the government decides, the federal government decides where they're going to put the money in. Are they going to put the money in HIV? Are they going to put the money in Hep C? Are they going to put the money in tobacco screening? So just wanted to show you what a comprehensive system we have here in Oklahoma and how we try to, and does it mean that we have done all the work? There's a lot more work to do. And we're just touching the surface, but we're working on it. And I wanted to talk to you about it because I do feel that, can you go to the next slide? Only 2% of the medical students go into primary care. I wanted you to take this home after our talk, and I want to think about this very seriously, that if you want to impact, you want to make a change in a broader aspect, you really need to get into primary care. And I know sometimes we want to be a surgeon, and then that's all fine, and we are all going to go into areas that what interests us. You know, somebody wants to go into OB, and somebody wants to go into this and that, and that's perfectly all right. But we can't have 2% of medical students going into primary care. We just can't. We just can't afford that. That's where I'm going to end. And it kind of seems abrupt, but that's where I'm going to end my talk. Thank you. Guys, have questions for me?
Thank you, Dr. Samant. We do have a lot of questions that students submitted beforehand. And then I know if people have questions right now, definitely feel free to speak up or put them in the chat and we'll read them out. But one question I want to start off with is, have you seen an increase in the people you've served since the pandemic has started because of things like job loss and maybe people losing their insurance? Is that something you've noticed?
Yes, we do get a lot of calls because yes, that has definitely happened. I don't know the exact numbers, but definitely increase in the number. But unfortunately, our homeless shelters are not able to pull them in because of COVID restrictions. And so I think the street homelessness has definitely increased. And we are working with the homeless shelters to try to make sure that people get in, especially during this weather. They do have a night shelter that they opened up, and which has actually helped. But yes, there has been an increase in joblessness and uninsured patients. There also, surprisingly, there also has been an increase in people wanting to know if they have illness, like people wanting to know if they have diabetes, or people who haven't cared for their health for a long time, like all of a sudden, like, oh, I might have diabetes, or I do have diabetes, I better get to the doctor. So because they're afraid that, they've heard that COVID-19 affects patients with diabetes worse than they affect patients with other comorbidities. So in a way, it's kind of made them aware that they do have illnesses that they need to address. So good and bad, yes.
Has it been difficult getting supplies or tests for your clinic?
No, initially we had a little bit of a hiccup, maybe in March, April, but no, not since then. We have had enough supplies that we can utilize.
Well, what would you say has been your biggest challenge since COVID began?
The biggest challenge with COVID began is, not being able to see your patients in person is very challenging, and doing telehealth when you have to really know that you have to see the patient to diagnose some things that you cannot do on telehealth. And patients are afraid to come in, or that probably has been a biggest challenge. Although it has opened up other things, like telehealth has been a good thing, because we do now access patients who would not have come in anyway. So we can call them and say, hey, let's just do a telephone call, let's just do this. And so we can take care of more things that way, but there are some things that you cannot take care of on telehealth.
That makes sense.
Yeah.
Has that been difficult for your homeless population who doesn't have access to
Yes.
computers?
It has been very difficult for them, and especially because they're in lockdown a lot at their respective shelters, because there are positive cases, and they're pretty much in lockdown since last March, and there's increases in the incidence of depression among the homeless population. They're already depressed because of issues, but I think this has just been very depressing for them, to not being able to get out of their shelters, to just walk on the streets and things like that. Yeah.
Someone asked in the chat, when you say that only 2% of physicians are in primary care, is that saying primary care alone, or does that include other specialties like emergency medicine or OB-GYN?
No, that's just primary care.
Okay.
That's what I read that somewhere. I hope that number is right, but this is, yeah, medical students are, very few people are going to primary care. Now, of course, there are nurse practitioners and PAs who do primary care, but in the last few years, there's less and less people going into primary care.
Let's see. Does anyone else in the meeting have any questions for Dr. Samant? Dr. Samant, do you have any advice you would have for us as students aside from going to primary care?
I think just do it with your heart and do it for the right reasons, and you'll do fine.
So,
yes.
Go ahead. Oh, sorry, I don't mean to interrupt. So I know that, like, especially the weather in the last week or so and coming up poses a really huge threat. Is there anything that we can do as medical students, like right now, to try and get people through the next couple of weeks?
As medical students, what can you do?
Yeah,
I think the Homeless Alliance website is probably the best website, and they will they usually list all the items that they need, and you can donate items as well as, donations, money. I think medical students probably don't have that money part, but they probably have the, maybe items like socks and blankets and things like that. And Homeless Alliance has a great a website, then you can find out what they need. Also, City Rescue Mission, they have a website that you can find out what they need. But generally during this time of the year, the biggest things are like hand warmers, foot warmers, that they don't have. This year, it hasn't been, the flu hasn't obviously been a big thing, so they don't need a cough medicine or something like that. But it is hard being on the streets. I think warmer, sometimes what they're missing that I find that the homeless shelters don't have is like, those ice bags that you get at the Walmart. Sometimes they may have a bruised leg or something and they don't have access to get ice bag, and they don't have access to ice. Sometimes they're able to just have that ice bag, even if in the cold weather, and put that on there. Just blankets and socks and those type of things, like I just mentioned, hats and mittens and things like that they probably need. And you will probably find a list on the homeless website, and so that way you're not buying some things they already have. So
I know that team-based care is kind of a more recent thing that we've been doing. Are there any free clinics that offer team-based care?
Can you tell me what you mean when you say team-based care?
So like psychologists working with doctors, working with whoever.
Okay. So free clinics, I don't know, but our clinic is not a free. Of course, our Healing Hands Healthcare for the Homeless is a free clinic. We do have substance abuse counselor on site, and so we do work as a team. We do have pharmacist on site, not at our clinic, but one of the other clinics. So I hope I answered your question, but I kind of got sidetracked there. Yeah, for a minute. Yeah. So yeah, I don't know about other free clinics, but I do know ours are community health centers, and we have a sliding fee where, like I said, for $30 a patient can get not only a patient visit, but a lot of times if they need CBC, CMP, a lot of the basic labs are covered under that. So it's a really good place to start when someone doesn't have insurance or uninsured or underinsured.
I know one of the big barriers for getting the elderly population vaccinated has been getting them help with getting registered on the government portal online. I know you said earlier that you guys have distributed, I think, over 3,000 vaccines is this to the homeless population? Like, what has that process looked like, getting them registered and vaccinated? We just asked them. Of course, we didn't have the system of the state to be able to distribute in that fashion. So in a way, it kind of helped, because we just use our phone and we asked them for their date of birth, and basically I really asked them name, date of birth, and 3 things, and that's it. If they were 65 and older, they're like name, date of birth, and something else. I can't remember what, maybe their race or something. That's it. And we just registered them that way, and we gave them, whoever came, we gave those 65-year-older. I think we did a pretty good job. I think 2,000 of our patients, we probably 65 and older
probably so far immunized. We have not been able to give the homeless vaccine yet. We just gave the homeless staff the vaccine, but we have not been able to give the homeless. We have not received the state distribution plan. We're waiting on receiving, hopefully, it's kind of slow in between, but hopefully we'll get it one day to be able to, that's our goal is to get all the homeless vaccinated.
When working with the state, have you experienced any barriers to getting the vaccines as easily as other hospitals like OU Health or Mercy? And similarly, did you experience any barriers to getting supplies and tests earlier in the pandemic?
Earlier, we had experienced some barriers, and I think part of that is the state and the federal run on their own kind of. We need to. This was an opportunity. Has been an opportunity for us to actually get together and work together. So it's been a good experience. We're just trying to build our relationships and trying to make it work. But I don't think it's just how the nature of the beast is. I don't think I would want to say that state put up any barriers or anything like that. It's just that there is not enough supply and the demand was so much, and we didn't have an infrastructure in place. And so, we're just putting infrastructure, and the state never played such a big role in anything in the past. So all of a sudden you're giving the state this huge role to play. It is difficult. You have to have the manpower, the expertise to be able to do that, such a big rollout. And I don't think any one of us had the manpower or the expertise, and we're just learning as we go. And we've learned a lot. We've gotten very far from where we were, but we are all working together in trying to make sure that we give access and we distribute the vaccine to everyone that needs it.
Thank you. That was a good answer. Someone submitted another question, and they asked, how much does your clinic rely on volunteers from the community, and has the pandemic affected the number of volunteers that you guys have?
Yeah, so we do not rely on volunteers as much as we could. I think that if you're interested in volunteering, it needs to be more. I know it's probably a specific question someone wants to volunteer, and because I do get an emails from a lot of medical students. It needs to be a specific amount of time, and it needs to be something that is concrete, etched in stone. It can be one day this and one day that, because we do have a clinic that we run. And so if you have to rely on someone to do something, then we need to rely on that person to do what they need to be doing. So there are some opportunities for possibly for volunteering, especially I think for people who are wanting to, from OU, I think there are a lot of students from OU that email me, and there are some opportunities, but if you're interested, I just email me and I'll forward that email to our quality officer and see if we can fit you in, because you have a schedule, you have school to go to, and you may not have the time that we want you in there. So that's usually the problem in volunteering. And we don't have you volunteer around patients. We usually have you do something in the back.
Thank you. Someone submitted another question, and I think you mentioned earlier in your presentation that you've been working with Harvard and Duke. Is that correct? To establish protocols?
We were.
Can you talk a little bit about what that process looked like?
Okay, so this was sometime in June or May or June of this year, when we had, they have an organization called START Coalition, which is, I think, with Global Health from Duke and Global Health from Harvard, Dr. Khashoggi and Tim Nicholson, I forget his last name, and OMRF, and they had some private funds, and they were trying to figure out how we can reduce the transmission of COVID-19 in the community and how we can start the economy back again. That was the thing for START, the START coalition, based off of the word start, means starting the economy. And so for that, they thought we can do multiple things. And one of the things was testing people frequently. The second thing was putting UV lights in shelters, to try to reduce the transmission. And I'm trying to think, there was a couple other, there was a multiple layer, and we were involved in the testing part of it, but it was a layered approach to try to mitigate the transmission, reduce the transmission and mitigate the virus, and develop a protocol for so that other people can use that same protocol for reducing transmission. So we came up with a plan of testing the homeless shelters every 2 weeks. And then if there was a positive case, then we would test them every week. And so we would isolate them and we would put them in a part of the city rescue mission. There was a area in city rescue mission that they isolated patients that had COVID so that the rest of them stayed safe. Because, in shelters, if one has it, it's gonna spread like wildfire. They're just so close to each other, no matter what you do, whether you wear a mask or you don't, because they're right next to each other. So with that, we would say that our positivity rate in the shelters reduced dramatically to maybe 1 or 2% compared to the outside, where we had about 5 or 6% positivity rate. So that was very interesting, very exciting for us to collaborate with big guys and be able to help the Oklahomans, the homeless in Oklahoma City.
We have a question in the chat here. It says that you have a combined education background of medicine and public health. Would you recommend that more future physicians have more training in the area of public health?
I would think so. I think that it would be important to understand how our system works, because we are looking at our system from just the eyes of the pharmaceutical drug reps who come in, or we're looking at it from a very narrow perspective. We're not looking at it as a system. We're looking at it from our own gain perspective as to, I'm going to go into this and I'm going to do this and I'm going to do that. We're not looking at it as what we are going to do as people. We need to start looking, the only way we start looking something as we is when we understand how, who those we are and how that works, how different systems work. Earlier, you asked me about state. That was a very good question, state and the city. And this is exactly, if you understand the system. Right now, there are so many partners. There's state, there's Oklahoma City County, there are all these counties. So if you understand the system better in public health, you will be able to make policy changes and impact health much better. And you won't duplicate your services, because a lot of times what happens is we're duplicating our services too. And no one is achieving what we need to achieve when we do that.
Thank you. That's a great answer. I think having the opportunity to maybe do a public health master's in med school is something that more of us should look into. It's definitely an interesting thing to think about. I think we have time for maybe one final question. Someone wanted to know what your thoughts on maybe what were the best, or what are some positives that have come out of the pandemic, and what do you think your practice will look like going forward, being different from what it was before? Oh yeah.
Oh, it catapulted us to 25th century. Okay, so we were kind of slow out there, but it made us innovative in so many different ways. And the things that we do now, we would have never thought of those things to do, especially telehealth. We talked about telehealth forever till we were blue in our face, but we never did telehealth. Okay, so that is a big one. Communication is obviously changed, and communication has changed now in your personal life, and so we have to just look at the good part of it, of this pandemic. We have to look at how we can move forward with it. It's never going to end. We cannot move away from it. So we move forward. This taught us how to move forward with it, is how to continue our lives and how to do the best we can with what we have.
Thank you, Dr. Samant.
You're welcome.
If anyone else has questions, just feel free to chime in, but I think we're near the end and that'll probably wrap us up.
Thank you, Tim, for giving me this opportunity to speak. And I enjoyed it. And I'm sorry about the earlier hiccup. I was just so cool about it. Like this, I keep doing Zooms and every day. And like, I never expected to have a problem because I'm always doing these meetings. So when you asked me if I needed help, I said, no, I got it. And sure enough, I did need help. Thank you so much.
Of course. And don't apologize. I'm glad it worked out. I'm glad you're here.
Yeah. Thank you.
Thank you.
Good job, Mom.
Is that my son? Is that my son?
Good job, Mom. You killed it. That was amazing.
Is he off the speaker? Thank you, Anoop. Thank you for joining.
It was amazing. Good job, Mom.
Thank you.
Yeah. Catch you
All
later.
right. Okay, bye.
Everyone,
I
don't
guess we could
forget
have
to-
asked everybody to listen to True. What is the name of the song, Tim? Just kidding.
Yes.
Just kidding. Yeah. All right. Thank you, guys.
Thank you. Everyone, fill out the survey at the end if you need to get credit for Alcha.
Thanks, Tim. Bye. I'm gonna leave.
Of course.
Okay.
Bye-bye. Sounds good. Thank you again.
Thank you. Just get this leave.